afternoon and good evening to all the speaker, chairs, and the wonderful audiences in different parts of the world. Welcome to the ACNS Webinar. The speaker for the first session today is our honored guest, Professor Krishna Kumar. Professor Krishna is the Professor of Neurosurgery at the Sri Chitra Tiruna Institute of Medical Sciences and Technology, Kerala, India. His research interests are focused on functional neurosurgery, surgery of the craniovertebral junction, minimal access neurosurgery, and neuro-oncology. He is also a noted author with several publications in various international peer-reviewed journals. His article received the Neurology India Award for the best neurology paper published about subthalamic stimulation in advanced Parkinson's disease. He's also an invited faculty to various conferences and workshops organized around the world. We are extremely honored to have him today in our webinar, and he will be talking about complication avoidance in deep brain stimulation. The speaker for the second session of today is our honored guest from United States of America, Professor Claude Hemphill. Professor Hemphill is the Professor of Neurology at UCSF Wales Institute of Neurosciences and Director of Neurocritical Care at Zuckerberg San Francisco General Hospital, United States of America. His research interests are focused upon stroke, cerebral hemorrhage, critical care, and intracranial hypertension. He has received several awards and honored for outstanding contribution towards neurosurgery. He's also a noted author with several publications in various peer-reviewed journals. He's one of the authors of recently published updated guideline in the management of intracerebral hematoma in the journal Stroke. We are extremely honored to have him today at our webinar, and he will be updating us about the recent guideline in the management of intracerebral hematomas. The chair for the first session today is our honored guest from Nepal, Professor Basan Pan. Professor Pan is the professor and head of Department of Neurosurgery at the Annapura Institute of Allied Head Sciences, Kathmandu, Nepal. He is also the past president of the Nepal Association of Neurosurgeons. His research centered on epilepsy, functional, and vascular neurosurgery. He's an important member of NESN, WFNS, and ACNS. He's also a recipient of several awards and honors for his outstanding contribution to neurosurgery in his country. He's a noted author with more than 80 publications and also invited faculty to more than 300 conferences and workshops all around the world. We are extremely grateful to him for accepting our invitation to chair the session of Professor Krishna Kumar. The chair for the second session of today's webinar is our honored guest from UAE, Professor Jamil Dibu. Professor Dibu is the session head, Neurology Critical Care Unit, Consultant Intensivist, Neurocritical Care, Critical Care Institute, Cleveland Clinic, Abu Dhabi, United Arab Emirates. He has completed his residency from UNCASS, followed by Neurocritical Care Fellowship at the Cleveland Clinic, Ohio, United States of America. He's also a member of American Academy of Neurology and Neurocritical Care Society, member Regional Middle East Chapter. He also has received several awards and honors for his outstanding contribution to neurosurgery. He's an noted author of several publications in the leading peer-reviewed journals and book chapters. We are extremely grateful to him for accepting our invitation to chair the session of Professor Claude Hemphill. On behalf of the Education Committee and the ACNS President, Professor Yoko Kato, I would like to welcome both speakers and chairs and the wonderful audience to this online platform of the ACNS webinar. A warm welcome to our colleague in China, and we are extremely thankful to Professor Zubin for broadcasting this webinar on the WeChat channel. With that introduction, I would like to hand over this online podium to our first chair, Professor Basan Pan. Professor, please.
Thank you very much, Professor Lee. It's always nice to be with friends once again. And today, from Sri Chitra, Professor Krishna Kumar is going to talk on complication avoidance in DBS surgery. As we all know, DBS is a functional neurosurgery. And so we need to bring in patients who are intact otherwise and make them better. So functional neurosurgery, the goal is to make the person better than before. So complication is, we need to avoid complication at all cost. And his talk will be very, very important for many people who are practicing DBS and other kind of, functional neurosurgery for movement disorder and other disorders as well. So without wasting much time, I will hand over the mic to Professor Krishna for his talk. Thank you very much.
Thank you very much, Dr. Basant. At the very outset, let me express my sincere thanks and gratitude to the office bearers of the ACNS, Professor Yokatu, Dr. Boon Seng Liu, Dr. Raja, for this opportunity to interact with the neurosurgeons of this part of the world and share our experiences with DBS and how to avoid the complications. In functional neurosurgery, as it has been elaborated just before by Professor Basant Pant, it is always wise to avoid complications rather than dealing with it and then addressing the problem after it has occurred. So to know more about complication avoidance, we should know at what all points or what all stages of DBS do complications occur. And then we will be wiser if we follow all the steps of the workflow in a meticulous manner so that complication is avoided. So DBS related complications, as you know, it can be related to the surgical procedure per se. And as neurosurgeons, we are almost like well versed with incidents like intracerebral hemorrhage due to an implant. We all do during our training days, and we train our trainees for ventriculoperitoneal shunt placement. So there can be intracranial hemorrhage, venous infarction, or there can be other small related events. Even an air embolism can occur due to at some stage. But in DBS, there can be stimulation-induced complications too, like dyskinesia, motor pulling, gauge disturbances, dysarthria, dysphagia. These are very distressing to the patient who is already not so normal like others. They are so unfortunate to have this disease. And there can, of course, be hardware-related problems which can occur, like hardware infection, hardware malfunction. The lead can migrate and get misplaced. And there can be some non-motor symptoms which can creep up. And if we are not aware, then it can cause catastrophic side effects. So let us see one by one. In the DBS workflow, first we have to be very stringent on patient selection. And there are routine pre-surgical checks which have to be followed. And in the pre-operative MRI, which we acquire, in our center, we acquire it a week before. There has to be certain points which need consideration. Then comes image fusion and you plan your target. And there is a stereotactic CT, which is done on the day of surgery when you fix the frame to get the coordinates. And many centers still follow the MER and the macrostimulation steps. But now sleep DBS is coming up in a big way, and there is a debate going on. Finally, the DBS lead is implanted and the post-placement imaging is done. And the steps involve placement of a pulse generator in the chest wall. And of course, there are some intricate steps involved in the program. So let us see one by one. In patient selection, one has to be very stringent in the sense that in the first 5 years, it is called the first honeymoon for the patient. This is especially for the patients with Parkinson's disease. The disease is well controlled with medication alone. So he enjoys it. But then the dyskinesia, the drug-induced dyskinesias become distressing to the patient. The off period becomes limited, so motor fluctuations occur. So once that occurs, then the next 10 years is the surgical benefit period. And advanced age and comorbidity and poor social support, we should not be offering DBS. So patient selection is very important. So a detailed understanding of the outcomes, it should be explained all the steps of the surgery and the perioperative follow-up and care, the need for follow-up, and they should have a realistic expectation about the outcome, and they should understand that surgery will not cure the disease or stop its natural progression. We are just modifying the motor effects or the motor mal-effects of the same. So the prerequisites for DBS for Parkinson's disease is, of course, the response is the patient should be levodopa responsive. So they are the best candidates for DBS, and they should demonstrate a significant improvement in motor symptoms during the off medication. So the exception may be tremor, but this is also debatable. So this is our DBS checklist for a patient with Parkinson's disease. He should have the diagnosis of an idiopathic period. That is why the first 4 years, there are some mimickers which progress in a way which is quite different from that of idiopathic Parkinson's disease. So positive response to levodopa therapy, absence of atypical Parkinsonian features, advanced disease, virtually unmanageable with dopaminergic medications, relatively young age. So here we consider something like age of 70 to 75 that we offer them something like lesioning, and they which can be invasive or non-invasive lesioning. They should have a normal cognition and absence of active psychiatric disease. This is very important. And good social support, so that there are social support and follow-up is integral part of deep brain stimulation. The pre-surgical checks, we should be very stringent to detect sources of infection. Actually, we got when way back when our center started DBS, we got several important inputs from our cardiac surgeons, because before implanting a heart valve, they look for several sources of infection. So like that, we have a thorough ENT check, a dental check, and a dermatological check for sources of infection. And if present, we address that, because one should understand that deep brain stimulation for most of the indications, except maybe for a dystonic storm or status dystonicus, it is a most elective procedure in the neurosurgical armamentarium. So it is elective. You don't need to perform it on the day which on a particular day. It can be done after the pre-surgical checks get over and the patient is cleared for surgery. So this is to be understood very clearly. It is one of the most elective procedures in functional neurosurgery. So there should be good control of the coexisting diseases, and anticoagulants, antiplatelet agents, some patients may take without the knowledge of the referring doctor. So we should interrogate them, and if they are under anticoagulants and antiplatelets, it is common sense that the concerned cardiologist or the specialist should be consulted, and it should be withheld for an acceptable period of time. We withhold it for a period of at least 7 days before taking up for surgery, and a good general physical examination is a must. Now, the patient goes for a pre-operative MRI. In our center, and I think most of the centers around the world, nobody will perform a frame-based stereotactic MRI nowadays, because it consumes time and the patient may not feel that much comfortable with a frame and undergoing a detailed investigation like MRI. So except maybe for dystonia, most of the DBS procedures, the pre-operative MRI is done several days prior to the procedure. So let us see what are the points to be taken care of when we perform the pre-operative MRI. The first and foremost is that the patient will never be at rest. He will have some, because it is of course done for movement disorders. So patient will have tremors in the gantry also. So the tremor factor will distort the image, and however superior your MRI machine is, there can be distortion of the image, which leads to the targeting errors creeping up. So your target, like subthalamic nucleus, the maximum diameter, as you know, is around 5 mm, maximum of 7 mm in some dimensions. So the tremor factor has to be taken. How do we do it? There should not be any compromise on image quality. go for sedation or go for an MRI under general anesthesia if the situation demands. But one should, at the end of the MRI, one should be very, very sure that there is no distortion of the image or the movement artifacts are not present. Choosing the right sequences is also a must, like the heavily weighted T2 images, the inversion recovery images. So each target has its own correct sequences to be followed. Once we miss these sequences, targeting becomes difficult. Alignment of the plane of the MR cuts, the plane through which the MRI is acquired, it should be aligned with the ACPC line. So this requires maybe if the radiographer is not very satisfied with the appearance of the AC or PC in the screening cut, the neurosurgeon should be sitting at the console guiding him to get the correct ACPC plane alignment in the planning MRI stage itself. And in some centers which have the system of when the merging is being done, some systems, the merging softwares take the first name of the patient as the factor for merging. So the problem is that there can be similar names and merging errors can occur without our knowledge, especially in high volume centers where many people are sharing the software. So it is better that you change it to the medical record number because each patient will have a unique number. So the unique numbers, the same number bearing patient, only the images will get merged. And it is said that we can do it on the day of the DBS itself. Yes, we can do it, but it is wiser to plan the pre-operative MRI at least a couple of days prior to DBS, because if there is any factor which we need additional attention, we can repeat it. We had instances where we had detected large basilar top, and because this is the first time that the patient is undergoing imaging, so we have detected issues like large basilar top aneurysms, very tortuous course of vessels, etc., which need more attention than is movement disorder. So, and there should be zero tolerance for errors. So even if we have to repeat the entire sequence, go for it. That is the importance of pre-operative MRI. The planning for the target, it should be performed after the image fusion, but always bear in mind that there can be fusion-related errors. And if you are following the principles of direct targeting, there should not be any image distortion, because image distortion errors will take you to another area which is not representative at all. So direct targeting, you have to avoid image distortion, and if the sequences are not proper, we have to address it. And there can be displacement of our desired target because of the ex-vacuo effects, because of atrophy. So one has to take care of or keep in mind of the ex-vacuo effects due to atrophy while planning the target. On the day of DBS, we have to fix the stereotactic frame, whichever make it may be. So the frame fixation, we also would like that the frame is almost aligned to the ACPC line. So we draw the orbitomeatal line on the patient's skin, mark it, and try to keep the frame aligned to that, because all the cuts then will get, the imaging cuts will get aligned to the, so there is no pitch, yaw, or tilt. The concept of 3-pin versus 4-pin, suppose the patient has undergone, he had some head trauma before and he has a craniotomy flap, then we will be forced to go for a 3-pin fixation, but ideal will be 4-pin fixation. And the clock starts ticking the moment the patient arrives your CT console, because the time factor, one should be aware that the more the patient spends time in your OR, the more uncooperative he is likely to become, because he has been deprived of the medications from the night of prior to surgery. So he will be, because the neurologist or the neurophysiologist, they want maximum tremors or the movement disorders on table to check for their macrostim and whether it is getting arrested. So for the patient, the awake patient should spend minimum time permissible in the OR. So the clock starts ticking because the first side implantation may go well. The second side he may become restless, and there are instances where surgeons have to postpone it to another elective. So always be ready to receive a torticolic tremulous patient for stereotactic frame fixation. It may be taxing for the beginner. So that is why one should spend some time fixing the frame on routine cases like thalamic lesion biopsy. Fix it for multiple procedures, then attempt it on a torticolic tremulous patient. And you should have a resuscitation station nearby, because after fixing frame, airway access may be slightly difficult. So if there is some kind of patient going for emergency situation like respiratory arrest or a vasovagal syncope, resuscitation station should be nearby. And one should have very good outer table haptics, because our pin should land only on the safe zone. The more we try to tighten, there can be problems like violation of the inner table, and then we have a different situation. So the outer table haptics and landing of the pin in the safe zone should be more. So once we have the preoperative CT with frame registration, many people, they resort to just putting a tape around the stereotactic frame and the localizer box. But always remember, these patients are tremulous. So if you have a rigid gantry adapter, that is always ideal. And it should always be a contrast enhanced CT, because it's always, that is when the fusion with the MR becomes most ideal. So contrast should not be omitted during the CT scan stage on the day of surgery. So you should have a very good IV access, because contrast administration at that time, we should not be looking for a good IV access. And there is an upcoming board, as you all know, for intraoperative CT and OM2, which is another discussion per se. And this is a question which is discussed in most of the stereotactic and functional neurosurgical forums. Why do we need a microelectrode recording, whether it should be single channel or we should have a classical 5-channel microelectrode recording? Should we do a macro strip? Okay, this we can discuss at your institutional level, but as far as complications are concerned, the more the testing electrodes or the macrostim stays in place, more will be the brain shift. So brain shift is actually the main menace as far as complications are concerned, in the form of there can be subdural air getting trapped. So all these can lead to significant brain shift, especially when you are doing the surgery for the next surgery. Suppose you are doing a left-sided procedure first, then moving to the right side, brain shift will be so the right side recordings and the right side placement can go back. So to control brain shift, what we usually do is that we limit the number of MER electrodes, minimum array tubes. I go for 2, maximum 3 nowadays. 2, and of course for the second side only 2, and usually macrostim also limited to the disability of the patient. And always I use fibrin glue as soon as the array tubes are in, to minimize the CSF. And positioning of the patient also, the head elevation I keep around 25 degrees, not too low and not too high. Another important point to avoid brain shift is there should be 0 delay while implanting the Dbs tube, because because that is the time when your fibrin glue is out, your array tubes are in place, so there can be chances for brain shift. So your image intensifier should be ready, the technician should be ready, 0 delay, and it is wiser to insert the Dbs lead, or suppose the anterior channel you obtain very good MER and there are absolutely no adverse effects. Don't remove all the array tubes or like the central or lateral in one go. Always put in the Dbs permanent electrode and then remove because Once you remove all the array tubes, the DBS electrode is going to take the path of least resistance. That may be one path which you do not want. So remove the array tubes only after insertion of the DBS. And always do a cross-table fluoro or an OARM check as depicted in the image and confirm that you are not gone too low or you are too high. And nowadays, many centers use devices like fixation devices like stim lock, which will prevent DBS lead migration. So lead malposition, I'm not going into details, but this has to be borne in mind that always be prepared for a repositioning if the lead malposition is detected. So you have these clues. That is where the macrostim also will help. And if you are too lateral, you have to move medial. If you are too medial, you lateral, anterior, ventral, medial, or posterior. So there are some problems which can come up in the later stage when there is lead fracture and lead migration. So one should not be very fixated that months after implantation, my lead is going to be at the same place. There are studies which have proved that lead migrates in all the axes, including because this, especially in the atrophic brain. And to find out the lead fracture, you may even have to take the patient to the cath lab and localize it with the 3D fluid. A post-placement MRI or CT, it is always wiser to get a post-placement CT or MRI and fuse with the pre-op images. And in the initial stages, it is wiser to do this before you put in the IPG, especially in resource-constrained countries, because of the, if you take the cost of a deep brain stimulation program, maximum cost is for the battery or the pulse generator. So if the leads are not in the appropriate position, it is always wiser to revise before putting the battery. And you all, of course, you can look for pneumocephalus, hematomas, and the stereotactic pin-related EDH, address it before you go to the next stage. So let us see one by one, what are the workflow-related errors. The neurosurgeon who is starting a DBS program should be very well versed with these workflow as well as the workflow-related. In the pre-surgical MRI, as I always said, image distortion error is your villain, and you have to address it either by sedation MRI or MRI under GA. Image fusion, there is no compromise for any image fusion errors. If the software shows that it cannot fuse automatically, go for a manual fusion and ensure that there is no image fusion error at all. And always stick on to the ACPC line plane, because we define the ACPC line, but we have to believe the software too much at this stage, and there can be image distortion errors, so one should be very careful with that. Frame fixation and fiducial registration can also lead to small errors. So if the frame fixation, after frame fixation and localization, if you find that more than 2 fiducials are out of place, go for a refixation or some kind of frame adjustment. Get another imaging and see that your fiducials are in place. Image fusion, as I said, image fusion errors can occur again with the stereotactic CT with the pre-operative MRI. And the XYZ coordinates and the ring and arc values, these are numbers suddenly encoded by the software. XYZ, at least we can draw the crosshairs yourself and measure it. But the ring and arc values are given by the software, so you have to believe it. But if you find that in your pre-operative planning, your entry point was pre-coronal, but suddenly after fixing the ring and arc correctly, you are seeing that your entry point is post-coronal, there is something wrong. Go back to all these steps and correct the error, and then only start the DBS procedure. Brain shift due to CSF loss, it can lead to volumetric error. Take all steps possible to prevent CSF loss. Bent array tubes are a real menace. As far as possible, go for fresh array tubes, but this is not possible in resource-constrained countries. They are very costly. So if it is bent, you have to get your biomedical engineer and repair it. Otherwise, localization errors will go. And the frame-related play on a tremulous patient. So the same frame, if it is used for 5 years, we found that after maybe 5 or 6 years, there is real problems with the frame alignment. There can be small inaccuracies related to that. And cross-table fluoroscopy, always correct the image distortion errors. Final DBS implantation, there can be lead migration unless some fixation devices are used. So there is no compromise on DBS lead final implantation. Take every step possible so that it stays in place. And always go for a post-op CT or MRI if possible before the IPG, at least in your first 25 or 30 cases. So now some specific complications related to IPG can occur, like if the pocket created is not very suitable, the sharp edge of the IPD can erode the skin and something like this can happen. So one should be very careful in the preparation of the pocket on the chest wall. And intracranial hemorrhage, most of these patients can be managed conservatively, and evacuation is, if it is attempted, don't go and enthusiastically remove the hardware also. Every attempt should be made not to remove the hardware, and usually recovery is not very good. And the same for venous infarction. And post-operative behavioral and cognitive problems. This should be educated to the patient as well as his caregivers, but the reported incidence of confusion is 5%, and there are some medical management or options possible. Care of the DBS wound is also where it is like the surgical steps. It is important to see that there is routine wound check, maybe post-operative 2nd day, 5th day, 7th day. And usually our practice is we give an IV antibiotics for at least 3 days and extendable to 5 days, suppose the patient is diabetic. Good glycemic control and digital control. Digital control, what I mean is the patient's digits. His fingers are the most damaging for the implants. So his fingers should always be under the monitoring eyes of either the caregiver or the staff. And he should not be touching the wound or scratching it. And there should be zero tolerance if infection is suspected. So what are the usual problems? We see a lot of suture knot related granulomas. This can be conservatively managed. They usually fall off. Cutaneous gapes because of over enthusiastic cautery use. And when a single breach can lead to clots. You can see this patient after years, the patient had come back with colonization, maybe due to some kind of hair procedure, and we had to take out the entire implant. So the barbaric activities, that is the barber who does the hair dressing, should be aware that patient has an implant and his skin is very delicate, and because these patients are aged, so occurrence of such incidents should be avoided. They have a very delicate skin. And the patient should be very careful with the pulse generator. This was one unfortunate patient who fell flat on his chest wall, got injured, and we had to evacuate the hematoma around. Luckily, the IPG was functioning well, so we did not have to take it out. But this is a real emergency sort of situation. And long-term care of the IPG, the patient should be taught to monitor, and the caregivers also, because such patients, they may come suddenly, they will come in a dystonic storm or breathlessness and remain because their IPG has worn off. And they should be taught well that if it shows end of life or at least 20% remaining, they should come to the treating center. And the cognitive derangement over time. So that is why the caregiver should be educated, because the patient's cognitive derangement, he may not be in a situation where he can do the care of the implants at a later stage. So this is the summary of the post-operative stimulation-induced urgencies and emergencies. But as I told in the beginning, once it has happened, it is very difficult. So we should try to avoid the complications rather than the complications to occur and then deal with it. It is altogether a different situation to handle. Thank you for the patient listening, and I'll be happy to take questions.
Thank you very much, Professor Krishna. That was a wonderful presentation, step by step. I learned a lot of things from your presentation, some very, very simple things that we miss, And So as you have said, in your starting, that patient selection is the most important thing. If you select the wrong patient, then the result is going to be bad. And almost all of us has done that mistake of selecting the wrong patient, operating on the wrong patient. So now we are more careful with our own failure and experience. We are also more careful about how to go. So as you also said very rightly about how to take the MRI, especially parallel to ACPC line, because usual MRI is not the lateral canthus, and like CT plane and MRI plane is different. So as you have rightfully said, we are fusing, so there can be some errors when you are fusing different planes. So as low as possible, the frame should be placed and then parallel to ACPC line below and above. It's wonderfully said. I don't see much question here, but because the question should be in the question box, right?
Yeah, yes, right. So far, no question. But I would like to ask some question, Professor.
Yeah, please.
Yeah. Professor, just wanted to find out regarding DBS, whether if a patient have a different indication, for example, you want to stimulate different part rather than the subthalamic nucleus, for example, is there any role of revision, let's say to treat certain other symptoms, for example, tremors or dyskinesia? So any role of revision, my first question. My second question, Professor, those patients who underwent lesioning but still symptomatic, is there any role to put in a stimulator? My last question, Professor, those patients on a pacemaker and require bilateral DBS, what are the options available? Thank you, Professor.
Regarding the first question, in the functional neurosurgery arena, the surgeon should be prepared for a revision for all indications, whether it is VIM implantation for tremors, VIM thalamic implantation for tremors, or the GPI implantation for dystonias. One should, if the desired effect is not seen and the post-operative MRI may be done after the lesioning effect is over, or if there is subdural air that gets absorbed, and if you feel that your placement is slightly away from where you should always offer a revision surgery for the patient. And nowadays, what I know from my colleagues who does directional lead implantation is that the number of revisions have drastically come down, because with the directional lead, you can somehow get the desired effect, even if the placement is suboptimal. But revision has to be explained and should be kept as a what we call plan B, in case the desired effect is not seen and the imaging shows that the implant is not at the well-optimized position. Second question is regarding patient who has already undergone a lesioning surgery. Usually, lesioning surgeries are procedures, and nowadays surgeons are performing invasive or non-invasive lesioning maybe 1 year later. But there are other targets which can be thought of if we have to plan DBS. So it will be unwise to have a patient who has already undergone a pallidotomy to implant a DBS lead in the same site. But we have other choices. We have the PPR, parapontine nucleus, or we have other targets like even subthalamic nucleus itself. The subthalamotomies, to my knowledge, is not very common. People usually go for a pallidotomy or thalamotomy. So such indications are there. Then one should offer DBS, but it may not yield the good effect if already lesioning has occurred to your target. And third is with a cardiac pacemaker. That's what I understand. For if the patient already has a cardiac pacemaker in situ, whether DBS is possible or not. To my experience, I have not encountered such a patient. and I'm not aware of any contraindication. For the industry tells us there is, because the only issue may be with the site of the IPG. It may vary because the cardiologists nowadays are also placing it on the left side of the chest wall or near the anterior axillary line. So we may be forced to do it on the other side. But when we undergo training for DBS, it has always been told that during those days, cardiologists were fond of placing it on the right side of the chest wall. So in case the patient needs a cardiac pacemaker, you should give the cardiologist some room. So we were taught to keep the left side. I don't know, Professor Basant Pant, you place it on the right side or the left side? We always place it on the left side because we were taught that the cardiologist in future, if he develops a electrophysiological cardiac problem, then the cardiologist would like to access the right side of the chest for the IPG. Thank you.
Thank you, Professor.
Yeah, can I add a little bit on that? So we are placing all our DBS right now on the right side. In the past, we were putting it on the left side, but we have, as Professor Krishna has said, we have left the left side for the cardiac people for future use, and there's no contraindication. You can put two pacemaker, cardiac and brain pacemaker. There's no problem at all. And about the tremor and thalamotomy, VIM thalamotomy, or DBS in VIM, we have never done a DBS in VIM. We do all VIM thalamotomy, or if it's a task-specific dystonia, then we go for BOA, BOP, junctional thalamotomy. And now for a central tremor, we are considering PSA, posterior subthalamic area, to add on VIM, BOA, or VIM plus PSA. So as Dr. Krishna has rightly said, we have considered we have not done it, but right now we have just recently considered a patient with DBS that we have put on subthalamic. He is good, but his initial step is not good, and he is always complaining about that. So for initial step problems, the gait problem, GPI is a better target than STN. So now we are thinking about making GPI listening on that gentleman and leaving the hardware behind as it works STN. But as Dr. Krishna has again said correctly, that STN listening is a very, very small space, and you can create a lot of problems because the space itself is so small. So we do not consider that. Yeah. And about very rightly said, Dr. Krishna has very rightly said, all patients that goes to the OT, initially they are very cooperative. And as we go down the surgery, then they start becoming uncooperative. And so this we have encountered many, many times. So what we have started doing now to avoid this complication is to take them to the OR, and then rehearse the same thing without the frame, and then you see what to expect, before actually doing the surgery itself. So this is something that we have been doing. And again, Dr. Krishna has already stressed this point, that you should have the 3D image of where you are going, even though, it's a XYZ given to you by the software, but you should know where you are going. And sometimes you are getting a wrong, information. And then when you are imaginingly, you try to put a probe, then oh, this is not the right place. So then you have to, redo the whole thing. To avoid that, we are doing, surgical planning and targeting on phantom before we actually do it on the patient. Are you doing that, Dr. Krishna, Professor Krishna? Phantom simulation?
No, we do not have the phantom simulation, but we at least measure. What I do is, after my planning on the preoperative MRI, on the scalp itself, I will see where exactly is my entry point with relation to two anatomical structures, maybe labella, orbit, or even this and the coronal center. So these are the things I keep in mind. And after the frame fixation on the CT scan also, I measure and see where my entry point is after the image fusion and ring and arc fixation. So if there is any disparity, then I redo the whole thing. I think the CRW frame allows you for phantom.
Yeah. And two of the complications that I want to share with you that we had was we did good job and we had complication. One was a patient with DBS. He became really, really better, but maybe our probe was a little bit too long and maybe we were stimulating a little bit too deep. And the patient went into depression. He had this depressing spell before surgery also, you know, and then he went into more depression. And then because of the DBS, he had enough courage to commit suicide. So there was one suicide in our series. And so this is a real complication of DBS, and we actually had one, you know. And another one was a dystonia patient where but for dystonia, we never put a DBS. We always do listening. And for this gentleman, we did a staged bilateral GPI listening. The stage was between 2 months. One was one side and then another was on two. And he was an alcoholic before he had this dystonia. You know, the dystonia was tardive dystonia, and he had psychiatric treatment, and then he developed dystonia. So after this surgery, he was shaking like anything before that, and then after surgery, he got better, and then he resumed his drinking, and then he became really, you know, alcoholic again. So sometimes, you know, you do a good thing, and then the result itself creates complication. That also we should bear in mind as a functional neurosurgeon, I think.
Good evening, Dr. Kusha. I'm Dr.
Please.
Risha from Nepal. I have one question for you, if you are hearing me.
Yes, we can.
Yes, Resha. Yeah, we can.
So having done, what is your experience of doing sleep DBS? Like now we have done quite a bit cases of DBS. We have felt that we have not a single case during which we had to change the lead after looking at the MER target. So now looking at the patient's discomfort during the DBS surgery, do you feel now that sleep DBS is better than awake DBS, or you still go for awake? So what is your opinion in this issue?
Thank you. Sleep DBS is always better for the patient because his comfort levels are extremely high in a sleep DBS. So what we usually observe is that as our planning armamentarium is very robust, our frame does not have any gaps or any loose screws or without any play. It's a very robust frame, and our image quality is absolutely up to the mark. We hardly have to ever change our trajectory or our lead position after MER and macro stim. So most likely we are going to implant it the central MER track itself. So in those cases, we are quite confident of doing a sleep DBS. But if in any center you feel that there has been instances where you had chosen the central track, but you had resorted many a time to anterior contact, or you feel that the imaging quality, what you see from your ears, it has to improve, or the frame is what I'm mentioning is that there are centers who don't have the luxury of having their own stereotactic frame. So the frame is borrowed and brought by the company who brings the other hardware. So that frame may not be familiar to the surgeon. So in those instances, go for a awake DBS, because many of the developing countries, they don't have the patients don't have that much financial support from the system. So they may be spending from their own pocket, as well as the law will be very stringent. So medical legal issues can creep up. So awake DBS is chosen in that angle also to prevent any reimplantations or to prevent any malpositions. But if the 3 points which I told, imaging is very up to the mark, the frame is a very robust one, and your experience has proven that in the last 50 or 75 dBs, you never had to change a single trajectory, then I think better to go for a sleep dBs. It is very comforting for the patient.
Thank you, sir.
Yeah, I mean, I absolutely agree with what you have said. Like most of the institute will start with awake, and as they go on, they are more confident, and then they are, selecting cases. Some cases they want to go for, general anesthesia, some local, and then eventually with MER backup, they are doing, sleep. So it's a matter of experience, as you have said, and then Dr. Reza is also asking that question because now that she has done quite a bit of DBS surgery, now she's confident enough to do it. Yeah, it's a matter of experience. Thank you very much. Yeah.
Mr. Pan, just now you say you will do some simulation. You allow the patient to come into OR. Say if you still get a restless patient, will you convert it to a sleep DBS, Professor?
Yeah, we give box of propofol, not intubate them, but then we of course give them box of propofol, and especially what right now we are doing is we are opening both skull at the same time, but we don't open both dura because of fear of brain shift, but both, skull work, because that's the nasty part, that's the noisy part, that's the nasty part. We finish with that as early as possible. And if we need a small amount of propofol to sleep them, but not intubation. Yeah.
Thank you. We have our second speaker here, Professor Taude. Professor, nice meeting you, Professor. So we just finished our first session. Probably we can hear the concluding remark from our chair, Professor Basan. Professor.
Yeah, it was a wonderful lecture, and I think, as I've said in the beginning, also, functional neurosurgery, you are talking about millimeters, and you are trying to make a functionally moving normal patient, bring them in, and then, ask them to pay a lot of money. So it's a lot of stress, but I think we need to avoid complication and zero tolerance, as Dr. Krishna has repeatedly said. I love that word, I will repeat that in my institute also. So step by step, he has, very elegantly elaborated how he has been trying to avoid. And I think we all have learned a lot. Thank you very much.
Thank you, Professor Basan and Professor Krishna Kumar. For your information, we have about around 850 audiences from all the three platforms, WeChat, YouTube, and also our Zoom session. And so I will hand over the platform to Professor Jamil Dibu to chair the second session. Professor.
Hi. First of all, thank you for the organizers for the invitation, Raja and your team. And it gives me a great honor to introduce Dr. Hemphill. Dr. Hemphill is someone I looked up to during my training. You read all about ICH, every other paper about ICH by Dr. Hemphill. So I was very excited to moderate this session where he'll be talking about updates in ICH management, which is something that we, there are a lot of challenges and the how much we can do for these patients. And now with our recent guidelines coming out, and I'm excited to hear about what can we do different and what are the things that we need to change to help these patients. So without further ado, Dr. Hemphill, one of our society founders and leaders, the floor is yours.
Well, Doctor, that's a very kind introduction, and it's great to see you again, Dr. Dibu, and hopefully I'm going to see you soon at some of our meetings. And I'm going to go ahead and share my slides. So can you see those slides okay?
Yes.
And my microphone's okay? Just want to make sure as we kick off.
Yeah.
Sounds great. Well, so I'm tasked with the discussion of intracerebral hemorrhage and updates in management. So what I thought I would do is focus on guideline-based management centered around the newest guidelines that have come out, the American Heart Association guidelines that came out just in May. That was an update. And that'll be a framework for us to discuss sort of where we are right now in terms of evidence for ICH treatment and where we need to go from here. So let's start with a case though. So this is a 49-year-old man with hypertension who had acute onset left-sided weakness, and he takes aspirin and a statin on a daily basis. And he's brought in by an ambulance to my hospital, Zuckerberg San Francisco General Hospital, ZSFG, and his Glasgow Coma Scale's 14. He's hypertensive with a blood pressure of 170 over 112, and he's got a dense left-sided weakness. And we see his CAT scan on the right, on the left, that has a right basal ganglia intracerebral hemorrhage with a little bit of right to left shift and a little bit of intraventricular hemorrhage. So the question is, what do you do? Do you take out the hematoma? Do we aggressively lower his blood pressure? Should we give him a platelet transfusion because of the aspirin that he's on, put in an intracranial pressure monitor, or really just sort of say, you know, let's just move to comfort measures only and not do very much, because this is a bad disease and we don't think people do well with it. And what do the guidelines say? Where do they give us some guidance on this? So just to remind us what we're talking about is we're talking about non-traumatic intracerebral hemorrhage, a particular subtype of stroke that is traditionally said to be about 10 to 15% of all strokes. But that really depends on where you live. First of all, in my particular hospital, it's about 25 to 30% of strokes because we get a lot of ambulance traffic. And there are certain parts of the world, I know that particularly in China, this is a very significant, more significant issue. And a lot of times it overlays hypertension and the ability to control hypertension at the population level. And we know that there's a very high morbidity and mortality associated with it. So ICH is a big problem. It's a problem for our patients, but it's a problem for our communities. And if I had to pick one message I could get out of all of this, it's, I wish we could put ourselves out of business. 65% or so of ICH is secondary to high blood pressure, hypertension. There is such a target for intervention for primary prevention. So I work in the intensive care unit, and I'm focused on patients after they've come in with ICH, but I'm always trying to give the message about primary and secondary high blood pressure treatment. Other causes that are increasing in number are cerebral amyloid angiopathy, which is often associated with dementia, and coagulopathy, and we'll talk about coagulopathy reversal. Sympathomimetic drugs can be an issue. These are primary causes. There's a lot of attention paid, understandably, to vascular malformations. Is there an AVM? Is there a cavernous malformation? This is a minority of patients, although I have a patient in my ICU right now who came 43 years old, who came in with an acute large right lobar ICH, who turned out to have moya disease. So we do see this. But we're not talking about ischemic stroke or traumatic hemorrhagic conversion or so forth. We're talking about primary ICH. And when we think about mechanisms, that's going to drive us in terms of our interventions and our guidelines. Primary being tissue displacement, brain herniation, and secondary being a big focus. Perihematoma injury, perhaps. Hematoma expansion, we recognize for a long time that's a big issue with coagulopathy. We know that it's a big problem. Maybe even a third of patients have significant hematoma expansion even without coagulopathy. What to do about that? That's a little bit unclear. And then cellular toxicity of blood products. The term neurohemoinflammation has kind of been used to talk about how blood is bad for the brain and blood breakdown products. So one of the challenges that we've had, and one of the reasons that we do need guidelines for ICH, is that evidence for optimal management in intracerebral hemorrhages lag behind ischemic stroke and subarachnoid hemorrhage. And this has led to dramatic heterogeneity in the type and level of care across, and sometimes even within institutions. And I find that I sometimes am guilty on rounds of saying, well, you know, in my experience, and I have to watch out because sometimes people say, in my experience, we need to be very aggressive. And sometimes they say, in my experience, these people never do well. And this has resulted in big problems in terms of understanding what really makes a difference. So, but ICH has been an area of very active study really for the last almost 20 years now, where it was largely ignored before that. So understanding of outcome predictors, mechanisms of injury, and targets for intervention, and hopefully beneficial treatments. So let's talk a little bit about guidelines. And you know, one of the things that most guidelines share is the intent to be evidence-based, meaning they draw their information from what's already been published out there in the medical literature. So it's not necessarily forward-thinking. A lot of good guidelines will identify knowledge gaps and future things that we need to work out, but they intend to be based on what we know up until now and should follow a specific process. Many guidelines follow something called the grade process. I'll show you the American Heart Association guidelines have their own specific criteria. And the reason this is important is when you look in the guideline itself and it says what the recommendation is and what the strength of that recommendation is, it's going to be based on that methodology. And I will admit that I prefer guidelines, whether it's in ICH or any other disease, that offer some type of recommendation. Because, I mean, these are experts getting together, trying to do the best they can. And I prefer offering some type of recommendation and then indicating the level of supporting evidence, even if low, as opposed to some guidelines which say, well, there's no evidence, we don't really have any idea. But, you know, different people differ. And we see guidelines in ischemic stroke and in traumatic brain injury and so forth that vary a great deal in terms of this. The American Heart Association guidelines have taken that approach where they say, we're gonna generally say something, but we'll tell you if it's low evidence. Now, there are a lot of guidelines out there, and one guideline document I thought was particularly well done in terms of methodology was the last European Stroke Association guidelines for ICH. But if you look at the way they did it, they used the grade approach, but they said they created recommendations based on evidence from randomized controlled trials, which means if there was no randomized controlled trial for the question, like, should you do intracranial pressure monitoring, they don't even really have a recommendation. And so, you know, there are new ESO guidelines focused on blood pressure and coagulopathy reversal that are more focused. But as I said, I'm going to sort of highlight these, not necessarily because they're the best, but perhaps because they're the most recent. They're the ones I'm most familiar with. And we really did try to at least say, let's come up with something to say, and then try to do it, and then understand where we've got to go from there. So these came out in May. And these are the 2022 guidelines for the management of patients with spontaneous intracerebral hemorrhage from the American Heart Association. So that's a lot of background. And now I want us to sort of really dive into things. So this is their particular class of recommendations. So you've got a class and you got a level of evidence. So class 1 is it's a strong recommendation. And this is where you get terms like they say is recommended. Or 2B class, it's a weak, they might consider. And then the level of evidence, multiple randomized trials, one or more at least, versus something like B and R, non-randomized studies, or C, EO, even consensus of expert opinion. So we've got a lot of experts on the call today and listening, or those that have varying levels of expertise. So I think how you interpret the guidelines in your own care, I think that's fair. And there's a ton of stuff in here. I mean, there's 12 different categories, but a lot of these have a number of different categories. And we're not going to go over all of these today. But what I want to refer you to is this is the sort of document that you can take in your own institution, in your stroke or ICU or emergency council, however you do your organization. And the idea is to take something like this and get together with neurosurgery, neurology, emergency medicine, nursing, respiratory therapy, whoever are the stakeholders from a provider standpoint, and make standardized hospital protocols and order sets that you can follow rather than making it up one approach at a time. And this is actually a level 1 recommendation in the ICH guidelines is use standard protocols and order sets. But so it's a very strong recommendation, but notice it's a BR recommendation. So what does that mean? That means that there hasn't been a randomized trial of taking care of people with a standardized order set versus not. And that's the sort of thing, I'm not sure there ever will be a randomized trial for that sort of thing. So I'm going to really strongly encourage you to take documents like this, bring it to your hospital, and have a standardized order set. But I want to hit some highlights for our talk today, and that is some of the basic aspects such as classification. So we're going to classify our patients based on clinical and imaging. What do we do about blood pressure? What do we do about coagulopathy? What's the role of surgery, at least from a guideline standpoint, and then everything else. And then for each of these, we're going to say, what do the guidelines say? Why do the guidelines say this? And what do we still don't know? So let's talk about classification. So classification, and this is important terminology difference. Classification is described in terms of understanding and identifying baseline severity. That's not understanding prognosis, okay? And that's really important. So there's a recommendation that a baseline severity score might be reasonable to provide a general framework for communication. But don't use a baseline severity score as the sole basis for forecasting individual prognosis or limiting life-sustaining treatment. And there's a ton of these scores out there. I mean, one general one that's commonly used is the Glasgow Coma Scale. But for ICH specifically, probably the most common one is the one we developed called the ICH score. But there's a lot of them out there. So I'm not saying you have to use the ICH score, but I'm saying it's a relatively simple approach that you take a clinical score like the Glasgow Coma Scale, some imaging, hematoma volume, interventricular hemorrhage, infratentorial origin, and then a demographic age. You put them together, you assign points, and then you get a score between 0 and 6. And it turns out that the higher the score, the more likely somebody is to die, the less likely they are to recover. And this has been prospectively validated. And as I said, there's the ICH score, but there's many, many others. But here's where you got to be careful. I think it means a lot when we're communicating, and I hear, and I'm going to go on rounds here in about an hour, and if they say, you know, we admitted an ICH patient overnight and they have a 45 cc left basal ganglia hemorrhage with interventricular hemorrhage, and their Glasgow Coma Scale score is 9, they have an ICH score of 4, I know that's a sick patient because I know a 4 is worse than a 3, but it's better than a 5. But if I go in there and say, what's the number? What's the prognosis? That's where I make mistakes. That's where I make mistakes because there's a lot of things that aren't in these scores. But let's talk about imaging classification a little bit. So that was clinical. First of all, just to remind us what CAT scans look like, there's typical locations where hypertensive hemorrhages occur: basal ganglia, thalamus, cerebellum, pons. This is where those deep penetrating arteries are that are beaten up by hypertension for years and years and years. And then lobar hemorrhage is not a typical location for hypertension, although it can occur. But when we see lobar hemorrhage, that's when we start thinking about coagulopathy, drugs of abuse, underlying vascular malformations, amyloid angiopathy, things such as that. Now, one thing I want you all to do, and I hope that in some prior schooling, you probably had to take geometry and you probably had to memorize the formula for a spheroid, 4/3 pi r cubed. And you may have said at that young age, when am I ever going to use this again? Well, I use it every day, and I hope you do too, in calculating hematoma volume. And so it's an easy, straightforward thing that we condense into what's called the ABC/2 formula. So let's just take our patient and figure out what's going on here. So this is the hemorrhage. So what you do is you pick the axial slice where you have what looks like, just by in general inspection, the largest area. A is the longest diameter, B is the longest diameter perpendicular to that. Then you take the number of slices times the slice thickness. You got to do a little bit of an offset here and be careful and not count slices that you just see a little bit on as a full slice. But let's say this is 6 centimeters by 3 centimeters. And we see it on 10 slices that are half centimeter size. So that's 6 times 3 is 18. And then that would be 5 centimeters in the up and down. That would be 90. Divide that by 2, it's 45 cc hemorrhage. So when you tell me this patient just got admitted and their Glasgow Coma scale is 9, and they've got a 45 cc right basal ganglion hemorrhage with some modest interventricular hemorrhage, that's a powerful way for us to communicate. Say the ICH score is 4, that's very, or 3, that's very helpful. But here's 3 things we don't know about classification. First of all, other factors that are important that are not in current baseline severity scores, and this is one way you got to be careful. You know, of course, we know intuitively that a young person without pre-existing medical problems is probably going to potentially have a different capacity for recovery than a very elderly person who's very frail with a lot of other medical problems. But most of these are not incorporated into into these scores. What about blood-based biomarkers? What about social support? Many different things. So I think it's important that we consider this, and that's why we want to use these as ways to communicate and classify, but not to precisely prognosticate. Because what we're trying to do is avoid the self-fulfilling prophecy of poor outcome. Going in there and saying, this patient is really sick, therefore, we're not going to be aggressive. Those are 2 different things. Saying this patient's very sick versus the decision-making on this patient is very sick. And there's a lot of research out there that's shown that the level of aggressiveness of care provided by the medical team is one of these other factors that's important that's not in a baseline severity score. And to me, that is really important because that's the art of being a physician. That means that we matter even beyond precise randomized trial evidence. And then can imaging markers be used to target treatments such as blood pressure lowering or hemostatics in agents in individual patients? Thing like the spot sign, which you give contrast, and if you see enhancement in the hematoma, it means that's a risk for increased hematoma expansion. So a lot coming on classification, but we're going to start simply by calculating the hematoma volume and calculating a score like the ICH score. You decide in your own place what you want to use. So what about blood pressure? What do we do? Well, there's a lot of different recommendations in the guidelines on blood pressure. And that's because it used to be thought of as pretty simple. And in fact, it's probably more complicated when we try to think about it. Is it better as a one-size-fits-all, or is it better as an individualized care? So we've got things in here like ensuring smooth control and avoiding variability, okay? Getting it done quickly within a couple of hours of onset or arrival. What's the target range to start? 150 to 220. So this is going to come from randomized trials where people with extremely high blood pressure weren't enrolled, okay? And what do we do? And does the baseline severity make a difference? So where does this come from? Well, first of all, how common is this? Well, we looked at our own cohort of patients, and it depends a little bit on how you define blood pressure. But if you say, I'm going to say high blood pressure is over 200, we still see that in about a third of patients. But if we say high blood pressure is anything over sort of the standard outpatient definitions, it's essentially everybody. This issue of blood pressure control comes up very often, even if the primary cause is not is not hypertension. So we're going to be faced with this question in almost every single patient that comes in with an acute intracerebral hemorrhage. And I was taught when I was at my early training that there was an area, here's our hematoma, but there's a big area around it that's vulnerable to lowering blood pressure. I mean, we know in acute ischemic stroke, if we lower blood pressure too much in those first few hours, we can actually make a ischemic stroke worse. And I was taught it's the same for blood pressure, because of a lot of animal models that found low blood flow in this area. But when subsequent studies in humans have looked at more advanced imaging, they haven't really found ischemia. So what's happening is there's a zone of badness around a hematoma, no doubt, but it's probably not ischemia. It probably has to do perhaps with this neurohemoinflammation. We see edema, but that may be due to the toxic effects of blood itself, as opposed to ischemia in most patients. Maybe sometimes, but it's not the big deal. So this emboldens us to think we could probably lower the blood pressure and not hurt the brain, okay? So let's study it. Let's do some randomized trials. And there have been several very large randomized trials that help us get some information. Interact 2 now is published, gosh, 9 years ago, over 2,800 patients. And what they did was they said, we're going to take patients who come in with this high blood pressure of 150 to 220 systolic. Not, it's pretty high, but not extremely high. And we're going to randomize them to 2 blood pressure targets, a systolic of 180 or a systolic of 140. And it's important when we look at the results of randomized trials to realize this was actually not a trial of blood pressure lowering versus permissive hypertension. They lowered it in both groups. They just lowered it more in one group than in the other. Okay. And they used whatever medication available. It was a very pragmatic approach and tried to do it for 7 days. Urapidil was the most commonly used agent, which is not an agent that I use or we have in our place. And they looked at, and it was done internationally, but a large proportion of patients were from China. And they looked at the outcome in a couple of different ways. And they found that there was about a 3.6% difference. It wasn't quite statistically significant in the functional outcome. There was a mildly statistically significant difference across the range of outcomes. We often use the Rankin scale as the most common functional outcome scale, with 0 being no symptoms, 6 being dead, and everything else being in between. 3 and 4 are kind of a common cut point because that's, are you able to walk or not? The problem here is there was a small difference in patient outcome, maybe statistically significant, no difference in hematoma expansion. So you've got to decide yourself, does it work? And is that clinically meaningful? Sort of another trial that was very similarly done was called ATACH-2. They did a little bit of different intervention. They still went to 140 or 180, but they used IV nicardipine for the first 24 hours. They said, we're going to try to really focus on this as an ICU problem, and we're going to get that blood pressure down quickly. And what they showed is, on the left, you see the blood pressure curves. Very effective at getting the blood pressure down. It really did what we wanted it to do in terms of the intervention. And in fact, if you notice that the average blood pressure in the 180 group ended up being like 140 or 150. And the average blood pressure in the 140 group was like 110 to 120. No difference in outcome, though, and there's an increase in renal injury. So what's come out of this is a lot of secondary analyses that are finding one of the biggest problems seems to be variability. And that's sort of interesting. It's a more sophisticated look than just picking a threshold. So the statistical look at the standard deviation of the systolic blood pressure. And they've looked in Interact and both of these trials, and we've looked in other data sets. And it seems like when you do measures like standard deviation and coefficient of variation and so forth of the blood pressures of patients in that first day, that turns out to be a big deal. A lot of variability is bad. That patient comes in with a systolic of 210, and I get it down to 130 within an hour, and it bounces back up to 200. And so I get it back down to 140 and then bounces back up to 195. That's probably bad for them. But I don't actually have in my medical record, I'll tell you what the blood pressure is, but I can't tell you what the standard deviation of my patient's blood pressure is in the first few hours. It's not something that we're measuring yet. So this is probably going to be part of where we go, but it's an idea of, can we individualize therapy a little bit? So here's three things we still don't know. First of all, we have to admit that we don't know if blood pressure lowering versus just permissive hypertension versus who cares, let it be 230, 240 systolic. We haven't done a randomized trial in that, but most people believe very high blood pressure should be lowered. So I think that, you know, we're not going to support the idea of not bringing down extremely high blood pressure. We're going to support that it should be done. And I think the question is, what is the target blood pressure? In our hospital, we've actually chosen 160 as a middle ground as our target so that we can avoid extremely low blood pressure and avoid renal injury and try to sort of minimize variability. But you get to choose. And I don't know if there's much of a difference between 140 and 180. That's for you to go back to your institution, come up with a guideline, and do it the same way every time at your place. And I think that variability is bad, but we don't quite know, you know, how. And I'll be curious if in the question session, if anybody says, yeah, we're actually calculating this and putting this in our medical record and telling us how variable it is. But it does mean that, you know, you probably need to not be using oral agents in these folks. We try to use IV agents if we can and keep it smooth. So let's talk about coagulopathy reversal. So we have a lot of patients who are taking blood thinners. They may be warfarin or other vitamin K antagonists. They may be the newer direct oral anticoagulants. Lots of people on antiplatelet agents. Most of these are for prevention of coronary artery disease, for prevention of stroke and atrial fibrillation and so forth. And we know that we encounter this a lot. We encounter it in patients who have trauma, but we encounter it for spontaneous intracerebral hemorrhage. So this was a very active area of the guidelines, and it's a pretty active area of both research and discussion right now. And so, you know, let's hone in first of all on the level one. The level one guidelines tell us what to do with these vitamin K antagonists. And they are use prothrombin complex concentrate if you can over fresh frozen plasma. Now realize that's an expense, and that may not be available everywhere. But as we'll talk about, it's clearly superior. And don't forget the vitamin K. Okay, don't forget the vitamin K. Probably even consider it in patients whose INR is not even in that therapeutic range, but is elevated. Now, what are we going to do with direct oral anticoagulants? Well, we'll talk about that in a little bit. And then antiplatelets, look down here. This is a level 3 harm, recommending against using platelet transfusions, at least for patients who are just on aspirin and aren't undergoing operative intervention. So where does all this come from? Well, here's the way I used to do it, you know, because I'm ashamed. I'll show you my cases from many, many years ago. 64-year-old woman, atrial fibrillation, hypertension. She was on warfarin, and she came in with a left thalamic, probably a left thalamic hypertensive ICH, and her INR was elevated. I don't think this was a coagulopathy-related hemorrhage. I think it's a hypertensive hemorrhage, but she was on warfarin too, because many patients have multiple medical problems. Her INR was too high also. And so she came in and we said, we have a protocol. We're going to thaw some fresh frozen plasma. We're going to give her 2 units. We're going to recheck her INR. We're going to do this over the next few hours because it takes time to thaw the fresh frozen plasma, but we have a standard approach, and this is what happens. Okay, and she has hematoma expansion and she died. And it was because what we were doing was too little, too late. And the thing that changed all of this from an evidence standpoint was the INCH trial. Now this is 6 years old, but it was done in Germany. Not very many patients, okay? Primary non-traumatic ICH within 12 hours, and it was patients with an INR that was elevated 2 or above. And their primary endpoint was, can you fix the INR? Can you reverse the coagulopathy? Secondary endpoints were mortality and hematoma expansion. So some type of clinical outcome, and then sort of a biological mediator, the hematoma expansion. And my goodness, you know, there's no question that prothrombin complex concentrates, 4-factor or 3-factor, we use 4-factor in our hospital, fix the INR compared to first frozen plasma. It just works so much faster. Just so much faster. You can get this in. There was a strong trend for mortality, but the study got stopped by the regulatory bodies because there was already a huge signal in hematoma expansion. And I remember when Torsten Steiner, who's in Frankfurt, presented this at the International Stroke Conference, he was very, very frustrated because his trial got stopped by regulators early, and they wanted to continue the trial. Even their Data Safety Monitoring Board had wanted to continue the trial, because one of the problems that we have in intracerebral hemorrhage is we may actually have biomarkers where we're fixing things like hematoma expansion, but we haven't had trials that have had clinical endpoints that have shown benefit in many cases. So they wanted to continue, but the regulatory bodies say you've already shown your primary endpoint and your hematoma expansion. So there are a few people out there I've heard who said, we don't use PCCs because there's still no clinical benefit, because there wasn't a statistically significant difference in mortality because the sample size was so low. I don't buy it. I don't buy it. And that's why it's a level 1 recommendation, because I think this works. This works. Okay, but it's got to happen quickly. Interesting study from a group in Germany looked at large cohort of patients, and they looked at blood pressure and anticoagulation reversal. And what they found is a synergistic effect of blood pressure lowering and coagulopathy reversal. And I want to throw this out there because it's a reminder to me that we study these things in isolation. We study blood pressure lowering. We study coagulopathy reversal. We study surgical intervention. And most of the time, we're saying, well, we're only going to include patients in the blood pressure trial if we don't have to lower their reverse their coagulopathy and they're not going to surgery. And it's so we can have a uniform cohort and we can study and understand whether that singular intervention makes a difference. But in our practice, all of these things are hitting our patients at the same time. And that synergistic effect of good clinical care, following the guidelines and bringing it together in that standard order set and that protocol is probably a bit of the secret sauce. It's a bit of what does make a difference for patients. So really, this speaks to this idea that we need to have that package of care. Now, what about the direct-acting oral anticoagulants? These are these newer agents that in some parts of the world aren't that new anymore. And we'll find even many places where the majority of patients, let's say, who have atrial fibrillation that's non-rheumatic in origin, are not even on warfarin anymore. They're on rivaroxaban or apixaban, these 10A inhibitors, or on dabigatran, a thrombin inhibitor. And there are now reversal agents that can work biologically on these particular agents. Iduricizumab, monoclonal antibody that takes out dabigatran. Andexanet alpha is a 10A inhibitor that sequesters factor 10A inhibitors. Problem with these, I'll just say it, I think, is two problems. One, they're really expensive, especially andexanet. Maybe the price is coming down, but this has been really expensive. And the way these have been studied, at least in the United States, has been to use a biomarker of hemostasis, but not necessarily clinical outcome. So I'm telling you, we have rivaroxaban at my hospital at ZSFG. We are not using andexanet. Some places do, some places don't, because of this, because of no trials assessing outcome. There may be new data coming around, but I'll show you what I mean by that. So this is from the andexanet study from 3 years ago. And they, there was a lot of patients in here who had intracranial bleeding. Some of it was traumatic, some of it was non-traumatic. And they said they used a measure of excellent or good hemostasis and said 80% of patients with intracranial hemorrhage who got andexanet had excellent hemostasis. And they defined excellent hemostasis as no more than 35% increase in hematoma volume after the first, I think it was 12 hours or day. The infusion was 12 hours. Yeah, so no more than 35. So does that actually mean that 20% of the patients enlarged their hematomas by more than a third? I mean, that's concerning to me. So I don't know whether this works or not. Okay, I want it to work, but I think we've still got to figure this out. So for now, it goes back to that hospital protocol. Do you want to bring this in? We're using prothrombin complex concentrates for those patients now, currently in my hospital. What about antiplatelet agents? Well, there was a randomized trial called PATCH a few years ago, 190 patients. Patients on antiplatelet agents, not undergoing surgery or ICP monitoring, no infratentorial hemorrhages. So, limited group of patients here. But they looked at platelet transfusions and looked at death or dependence and found that platelet transfusions were associated with harm, more serious adverse events, and the patients did worse. So this is why we are not recommending platelet transfusions. Now, before I get to sort of the three things we don't know, I do want to bring you back to the guidelines. One of the things we've obviously seen with the coagulopathy, it's kind of gotten a bit complicated. And so we do need something that helps us standardize our care so we don't have to be making this up in real time on an individual basis. This comes out of the guidelines. This is a flow chart that was put in the guidelines. So you can pull this out of the ICH guidelines and consider it for your own particular protocol. And so it both tells us what we might do for particular agents, what we might care about in terms of history, like for the direct-acting oral anticoagulants, and what class of evidence it is for particular interventions. It's even color-coded, which is kind of nice. So use these flow charts as shortcuts that allow you to get yourself some standardized order set. So one question is, how fast do we need to do it? I mean, time is brain. We talk about 60-minute time, door-to-needle time for ischemic stroke and thrombolytics. Is there a door-to-needle time for coagulopathy reversal? We're pushing that. We think there should be. Does reversal of DOACs improve patient outcome? I want it to. I hope it does, like prothrombin complex concentrate does for patients with warfarin or vitamin K antagonists. But I think there's a lot of interest in this. This is going to get clarified. And then what about other antiplatelet agents? Clopidogrel, we're more concerned about clopidogrel than aspirin. And what about patients going to the operating room? I will admit that we will often do platelet transfusions and DDAVP in patients who are going to the operating room who are on clopidogrel especially. Now let's get to surgery. We're in a neurosurgery forum and we want to know who to operate on, okay? And so this area, once again, has gotten more complex. And I'm glad for that, because I will admit, I was a little bit concerned when we did the 2015 guidelines. There were people in there saying, see, we've proven surgery has no role. And that's really not the thinking now. The thinking is surgery has a role, but we still haven't clarified exactly how we should be doing it, what patient selection and so forth. So where are we right now? Well, we divided it up into minimally invasive craniotomy and craniectomy because these do seem to make a difference. And there's only one level 1 guideline, and that's for cerebellar ICH. And it's actually a BNR because there's not a randomized trial of cerebellar ICH surgery versus just letting people go. But we're going to call cerebellar ICH in patients who have brainstem compression, hydrocephalus, ventricular obstruction. We're going to call that a surgical emergency. Okay. What about minimally invasive surgery for interventricular hemorrhage or for intracerebral hemorrhage? Well, we'll talk about a couple of trials that have led to these recommendations for at least reducing mortality. Okay. And then craniectomy, much less data on this. But these are all things that it's moving forward. So the CLEAR 3 trial was a study of intraventricular hemorrhage, and it's about 500 patients. And the idea was instilling tissue plasminogen activator, alteplase, via ventriculostomy into the ventricular system versus saline placebo. So all patients got something instilled in there. And they did it up to 12 doses, 8 hours apart. So this was not necessarily a hyperacute surgery. It was a surgical intervention via a ventriculostomy that could have lasted over 3 days. So they sort of looked at two things. The first is, are we getting the blood out? And are there complications? And the second is, does this make patients better? And we said we use that MRS of 3 or better. Are they walking at a year or not? So what did we find? Well, the first thing we found is absolutely, this clears blood faster. And those of you who have used this either in clinical trials or for clinical care know that this is a way to clear the blood faster. Okay. But what we found in this trial is it definitely saved lives, but it didn't change disability. Okay. So this has led for a lot of discussion on, is this a treatment we should be using now? Is mortality enough? Where do we go from here? Now, what about surgery for intracerebral hemorrhage? Well, it's been 17 years, it's been almost 20 years since the first big trial, Stitch, was completed. And this was a landmark study, but I'm going to say this is an old study now. It really looked at whether early surgery should be done or not using a craniotomy. Okay. And so what we found is there was no difference in mortality or functional outcome, but about 1 out of 4 patients in the non-surgery group crossed over to surgery later. So it didn't really answer the question of, does surgery make a difference or not? It just didn't find that maybe evidence favored early surgery in a one-size-fits-all approach. And we know that Stitch 2 was done to look at lobar ICH that was within a centimeter of the cortical surface, something closer, in patients that were conscious with no interventricular hemorrhage. Interestingly, about 1 out of 5 of these patients crossed over from the non-surgery group and got delayed surgery. So once again, no difference in outcome, but it is kind of interesting. They did a post hoc analysis where they had taken this score that was a prognosis score developed from the first Stitch trial. And what they found is, well, if you had a poor prognosis, surgery might actually be good for you. Whereas if you had a good prognosis, it didn't matter. Maybe even favored non-surgery. And I guess what I'm asking myself is, if somebody's got a good prognosis, why am I sending them for surgery anyway? Because they're going to do well. So it is only the poor prognosis group that I would think about the need for an intervention such as surgery anyway. So we can't really necessarily use this to completely justify surgery, but it starts to tease at the idea, starts to get at the idea of patient selection. Now, there was a big multi-site sort of cohort study that looked at cerebellar hemorrhage. And this is not a randomized trial. But what they did find is the patients that got cerebellar surgery were more likely to survive, but there wasn't a change in disability. This study and Stitch 1 and Stitch 2 did not actually test whether the surgery was effective in terms of getting the clot out. It tested whether they went to surgery or not. Now, I want you to hang on to that, but I think our neurosurgeons here would probably recognize that if you did a trial of whether a brain tumor patient went to surgery or not, but you didn't take out much or all of the tumor, that's probably not a very fair way to study that. But that's the way the ICH studies have gone previously. It's not really whether the surgery was done well by experts, whether it was done or not. Now we're moving on to minimally invasive surgery, and this is not a new idea. It's been around for a while, but the studies and the interest has really accelerated. And there's three basic approaches. One is using an endoscope, one is stereotactic aspiration, and the other is addition of thrombolytics. And I think it's really powerful that we now have increased attention to technique refinement on this. It takes expertise to do this right. And MISTY 3 was a randomized trial that was sponsored by the U.S. National Institutes of Health, came out a couple of years ago now, 500 patients, and they looked at patients with hematoma volume at least 30 cc's that was stable, it wasn't expanding. And what they did was they said, we're going to put a catheter in the hematoma. We're going to have a very careful standardized approach. We're going to make sure the catheter is in the hematoma in the right way. We're going to do post-placement CTs. We're going to do that installation of TPA every 8 hours for up to 9 doses. We're going to stop when we've done what we wanted to do and get the hematoma out. We're going to see how patients do. So what did we find? What we found is, once again, it saved lives, but it didn't change functional outcome. But there was a decreased mortality in the surgical group. But if the procedure did what it was intended to do, it did help patients. If you got below 15 milliliters in the final volume, you had less intracranial pressure and you had better outcome for patients. Now, that wasn't what the study was designed for. And so some people could certainly look at that and say, never do this again, didn't work. But there was a companion analysis of this that looked at surgical performance. And I mentioned this about better functional outcome if the procedure actually did what we thought it would do, less intracranial pressure elevation, but it shouldn't be surprising. Greater surgeon and site experience was associated with procedural success. People need to be trained in how to do the procedures correctly, and they need to do them correctly. This should not be surprising. What really surprising to me is this has not been our expectation of surgical ICH trials previously. Why would you ever do a trial of coagulopathy reversal if of PCCs in warfarin-related ICH if you weren't showing that you were fixing the INR? Why would you do a blood pressure lowering trial without showing you're actually lowering the blood pressure? Why would you do a surgery trial without showing you're actually doing the surgery well? And this is a huge lesson from ischemic stroke and embolectomy, where we saw many of the initial trials of neurointerventional approaches for ischemic stroke maybe were beneficial, maybe actually weren't. But as procedures got better because the practitioners were better trained, the devices were better, and we started getting recanalization rates that were very, very high, the patients did better. So I'm hoping that what we're seeing in surgery for ICH is that same thing we saw in embolectomy for ischemic stroke. Better devices, systems of care practitioners, and hopefully patient selection. But we're on the path. So 3 things we still don't know about surgery. Well, there's strong interest, okay? So don't take away the message that surgery doesn't have a role. But I think we still need, even while we may do it now, and we've had actually 3 patients at San Francisco General in the last 2 weeks that we've done ICH surgery on. So we're still doing it in patients we select. They tend to be younger, and they tend to be patients where we feel like the hematoma is accessible and so forth. But the issues we've got to resolve are things like patient selection, type of device, and surgeon experience. And there's several randomized trials ongoing right now, and some of you may be part of these, looking at minimally invasive interventions. Is mortality a sufficient benefit to drive care right now if we're going to use that trial data? And is anyone going to be willing to randomize patients with cerebral or ICH to no surgery or not? That's a tough ethical question. So I want to finish up by hitting a few highlights on that everything else category. First thing is, it's really interesting to me that in these ICH guidelines, and it's been in several iterations of it, several versions of it now, there's actually a section on decisions to limit care or not. And this is not a section saying you may want to think about limiting care. It's saying be very careful. Aggressive care for intracerebral hemorrhage is recommended early in the course, even if patients are severely affected, unless they come in with pre-existing requests for limitations, as some patients may do if they have pre-existing comorbidities or so forth, because it's a self-fulfilling prophecy. If we give up before we get started, of course the patient's not going to do well. We recognize that there may be cultural differences in this around the world. And I've had some places say, this isn't an issue. We don't use do not resuscitate orders on anybody. And that's fine, but maybe that's not the marker of aggressive care. If you don't use do not resuscitate orders, but you say, if they're an ICH score of 4, we don't put them in the ICU and we don't send them to surgery, oh, you're doing the same thing. So I think there may be cultural differences in the use of orders like that, but there may also be cultural differences in what you are viewing as limitations of care. So we're going to come back to that top and say it's about giving aggressive care if that is concordant with what patients and families probably want. And then there's a whole bunch of other issues. And I'm going to refer you back to that guidelines document because this is stuff that comes up. Should we do ICP monitoring? Well, class 1, if they got hydrocephalus, interventricular hemorrhage, decreased consciousness, yes. Should we do ICP monitoring outside of that? Many places do, but there's less data for that. Don't use steroids. Steroids don't seem to help. It's not a steroid responsive disease. May actually be harmful, especially for hyperglycemia. Factor 7A and TXA haven't been favorable in phase 3 trials. There's a couple of other trials that are getting going in this. We'll see. For now, they're not recommended. And then prophylactic seizure medications, not recommended either. But it is recommended to treat seizures if they occur and to really consider monitoring of the EEG if we're not really sure. And then I've got to mention something that just isn't exciting. Maybe it's exciting for some people, but it's not exciting to think about DVT prophylaxis. But this is actually very important. And it's a class 1, level 1 recommendation that patients with spontaneous ICH should get these pneumatic compression stockings. Not stockings, I'm sorry, intermittent pneumatic compression devices on day 1. As soon as they come in the hospital, as soon as they come into the intensive care unit or stroke unit or wherever you take care of these patients, do that. Maybe in a couple of days, you could start sub-Q heparin, but it's a 2B recommendation. There's so much discussion. Should we start heparin? Should we not start heparin? Should we start low molecular? The key is get those intermittent pneumatic compression devices on as soon as possible if you have them in your place. I realize these cost money. Why is that? There have been a bunch of randomized trials in stroke patients, including ICH patients. And look at this bottom one. This is really where you get a lot of different 17% versus 6.7% DVTs in patients. So you drop a huge number of DVTs just by pneumatic compression. So that's really the message here. So let's conclude by saying innovation in ICH in the last decade or so has included completion of large medical and surgical trials. We can do trials in this. That's important. And advances in understanding of injury mechanisms and trials based on these, and there's more to come. And so guidelines exist that really should form the basis of current care. Let's use these for our own hospital order sets. Get together with your local team, your local experts, and decide what your hospital order set is going to look like. But it's also a set of questions that need to be answered. And every big section in the AHA-ICH guidelines talk about sort of key questions for the future. And that's why I put those in, not to keep us from taking care of patients now, but do it now and be part of solving the problem for the future. I think guidelines are meant to be used now and improved on in the future. They're here to help patients, not to punish medical providers and say you're doing things wrong. They're here to help us, to give us an even playing field. But I am going to emphasize that even in the absence of a specific highly effective treatment for a particular issue, nihilism is an ineffective treatment strategy. What you do for aggressive care for your patients makes a difference. So thanks a lot. I'm going to stop the share now and see if there are any questions.
Thank you, Dr. Hemphill, for a mind-stimulating talk about an important topic. Before I hammer you with the questions, because I can take over that session, I will ask one of the Q&As. And for the audience, if you have any questions, please type them in the Q&A box. I have a question by Dr. Parech. Is Harchad, if any method of evacuation of ICH, what's an improvement in neurological condition versus early versus delayed? I guess, is there a difference between early removal versus delayed? And then is there any advantage between minimally invasive versus standard craniotomy?
Yeah, and I think those questions, I mean, that's part of the question that I tried to get at in showing the different trials and so forth. So the evidence-based answer is we don't know yet. Okay. I can certainly give you my opinion-based answer is that there is a concern about ultra early clot removal. And I think that ultra early meaning, that patient comes in within an hour of their ICH and you take them to the operating room. There is a concern, and there were some small studies that suggested that you can get in trouble with ultra early bleeding. So it's probably reasonable to consider a period of stabilization, maybe a follow-up CAT scan. What I've seen some people do is they'll do a contrast enhanced CT and show that there's no longer a spot sign, that there's no contrast extravasation. But once again, these haven't been studied in detail. I think that delayed clot removal, it depends on what you mean by delayed. In some ways, that MISTY trial is a delayed study because it's like a 3-day intervention. And I'm really wondering whether that's part of the reason why it's not as effective. I'm going to be very interested in these minimally invasive studies that look at patients being treated, like in the first day or so, and that use endoscopes and really get the clot out. Minimally invasive versus standard craniotomy. Minimally invasive is probably the future here. Standard craniotomy, if that's all you've got, the last patient that we had was done because the endoscope wasn't working. My neurosurgical colleagues went ahead but it was a lobar hemorrhage, and they did a small corticectomy and got a good clot evacuation, and we'll have to see how that goes. Non-contrast sign,
yeah, go ahead. So the non-contrast sign, what do you think about it? CTA, it's also another question pops in. If you see that spot sign, or as far as prediction, like what will it change? Like how will you act on it? And do you really look for it every single time?
Yeah. So so one thing we didn't really talk about, because it's a big topic on its own, is signs on CT scan that are predictive of ongoing hemorrhage. I mentioned the spot sign, which is the where you give contrast and you see contrast enhancement, a dot or a spot in the hematoma. There are a number of other studies. People have looked at the swirl sign and the blend sign and the island sign and a number of different things you might see. And they may actually, on non-contrast CT, be sort of equivalent or give us the same thing. The question is, if we see any of these, so first of all, the answer is, we do look for those in my center. We do. But how does it change my management right now? I think the main thing it does right now is it heightens the awareness of this being a patient that needs close monitoring for potential deterioration. Even though it shouldn't make a difference, sometimes it scares people into getting the blood pressure lowered or getting that prothrombin complex concentrate mixed up even a little bit faster, although they ought to be doing that on their own even without that. But the studies, there have been a couple of small studies using factor 7 in spot sign positive patients, and they were very small to enroll, and they basically were non-informative. So I don't know. I think that's going to be important, but I don't know in the future.
And I think that answers Hamid's question. Maybe I'll squeeze in one of my questions. It's interesting to hear at your center you kept the 160 as a systolic target blood pressure, and I know it's going to be different between one patient to another. But what about that patient that comes in with a 150? I mean, do you just lower it below 140? And what about those that you know, they come in too high, then suddenly it's a hypertensive location, then they're normotensive because it's the egg of the chicken, and then they bounce back the second day. So you just focus on not the number, the lower limit, not to go too low. What's your take overall on the ones that throw you off and not being too hypertensive?
Yeah, you know, if they come in non-hypertensive or modestly hypertensive, we're still just kind of keeping them in that range. There are a subset of patients that are very ill that we will be doing ICP and even advanced monitoring like brain tissue oxygen monitoring in or so forth in order to say, is this a patient who needs a individualized approach? But for most patients, we're still trying to target that number and keep it, reduce variability. It's a fair question, how long should we do it for? In Interact 2, they had intent to do it for a week. In ATACH 2, they said, we'll just do it for a day, although they went back to 180 as their threshold on everybody for a day. So, we certainly do it until the patient's well enough to get out of the ICU.
Yeah, and as a follow-up question about blood pressure, I mean, when is, the patient's there for a few days, underwent complications, when do we start targeting normal? Like, when is 140? When are we going to treat them as an outpatient because they're out of the initial phase and you're not too worried maybe about hypoperfusion anymore?
Yeah, I think if we're taking out that subset of patients that are really critically ill with intracranial hypertension and issues of cerebral perfusion and so forth, then I would say after the first day or so, we're not rigid on that, but we're starting oral antihypertensives, even if it's by feeding tube, and certainly in patients that can swallow. And my long-term blood pressure target for, I put in the chart, this patient needs blood pressure less than 130/80 long-term, because they've already had end organ damage, and that's actually in the guidelines for secondary prevention. And it gives my primary care doctors, my cardiologists, or whomever, my vascular neurologist in the outpatient setting, a target rather than just saying blood pressure control. So.
Very fair. Thank you, Dr. Hanfeld. So another, Dr. Ayman is asking, is there a way to reverse the harmful effect of blood in the brain, meaning like endotoxicity, like the inflammatory part of the blood?
Yeah, so this getting at that neurohemoinflammation concept. So I think what I have to say right now is active area of study, but not a don't have an answer yet. I think that may be one of the beneficial effects of getting the hematoma out surgically, actually. But there was a phase 2 trial of deferoxamine, the iron chelator, and the idea that you're going to help perihematomal edema, and this was in non-surgical patients, and it didn't make a difference, and so they didn't proceed to phase 3. So I think there's a lot of interest in this right now. It's sort of like neuroprotection for ICH. We don't have that. I don't think that osmotherapy is solving that problem. And
one last question from the QA box so far is, role of life-saving surgery in ICH patients who are excluded from RCTs is maybe, I guess these are the high-grade ones or the ones that you would follow the self-fulfilling prophecy.
Yeah, no, I'm glad you brought that up because that was something that we chose to really struggle with when we developed the guidelines. And it would have been so easy to just say, no role for surgery, no improvement. But, you know, this is a group of patients that doesn't get studied. The patient that comes in extremis. And what do we do? I think that the cerebellar surgery story is a little bit of that because we've had that experience with case series and cohort studies and so forth. And many of those patients are very sick, and it seems to be favorable. So I would say this is an area of great heterogeneity. I'm proud that at least in our ICH guidelines group, and you'll see I didn't put up every single guideline for surgery. There's actually one in there that addresses this. But we had a number of neurosurgeons on the panel that were very willing to entertain that. So at our center, we look at things not just baseline severity, but medical comorbidities, age of the patient, frailty, things like that. And if it's consistent with patients' wishes, we will offer that as an upfront treatment in order to see how things go in the coming days. So I encourage us to be open to that.
I'll squeeze in a question quickly in regards to frailty, and you mentioned a lot of things outside the ICH score that you consider while talking to families and managing them maybe. Do you consider revisiting the ICH score that you developed many years ago and including coagulopathy, for example, studying that frailty premorbid state? Would you consider that and revisit the ICH score like a modifier?
I'll tell you why I'm not. Okay. I remember when we developed the ICH score, and it was really because we had a communication scale in ischemic stroke and in traumatic brain injury and in AVMs and in subarachnoid hemorrhage, and we didn't in ICH. And we developed it purely for that. And I feel like some of my research into self-fulfilling prophecy and care limitations has been a little bit of penitence for developing the ICH score and having people use it in ways that I never really intended it, because I want us to concentrate less on trying to come up with the perfect outcome prediction scale and just focus on communication and aggressive therapy. So I hear you, but I think I'm not going to go back and add 8 things and call it the ICH score 2. I think I'm going to try to move to getting minimally invasive surgery solved or something like that.
And that last question, I think, on the Q&A before I ask my panelist colleagues if they have any questions. Is there a role for prophylactic hypernatremia, probably with the ICH score, obviously with surrounding edema? Do you start them right off the bat? Do you wait till they develop some shift? What are your thoughts on that?
So, the evidence-based answer is we don't know because it hasn't been studied. I think the answer is probably no. I think prophylactic hypernatremia is probably not going to be helping that edema, because that edema is probably due to blood toxicity. And the one thing that we have identified, we talk about this in our center, how ischemic stroke and even traumatic brain injury, but especially ischemic stroke, the peak edema period is often at 3 to 5 days. The peak edema period for ICH can be much longer. And that's been studied using MRI studies and so forth. These folks can have edema periods out to 8 to 10 days or so, and it's probably because there is the blood toxicity. It's just a different disease. It's not ischemia, and so I think that at this point we are more reactive than proactive, at least as it relates to osmotherapy.
Thank you, Dr. Hempel. I'll leave the room for my fellow panelists and organizers if they have any questions. I don't see any in the Q&A.
Professor Krishna, would you want to comment?
It was wonderful listening to you, Claude and Phil, and we learned a lot. And I think some extrapolation to the pediatric population will also occur because the guidelines are never similar. The occurrence is not that frequent, and the management pattern followed in several centers differ so much. So thank you so much for the information.
No, it's a very good point, and certainly we have a very active pediatric neurology stroke group at UCSF, and I think what they've really seen is what folks see probably in your center and others, is that there's a much higher rate of vascular malformations in children who come in with intracerebral hemorrhage, and that needs to be at the forefront of our mind when a child comes in with an ICH.
I have some couple of questions, Professor. Thanks for a very great lecture, Professor Hempfield. I just want to find out, in the context of a Cushing reflex, those patients with a larger intracerebral hematoma or with a lower Glasgow Coma Scale or younger patient that we do not expect have brain atrophy, would the degree or the rate of lowering blood pressure be slower, or we targeted a higher blood pressure? With the same context that in my experience, in those patients who have very difficult to have blood pressure control by medication, I always find that surgery do offer immediate blood pressure control. Is the same observation happen at your institution? My last question, Professor, what are the indication of surgery in those with Glasgow Coma Scale of 15? Is there any indication, or there are also another group that we would not put in the study? Thank you, Professor.
Yeah, so so those are good questions, and let me make sure I got all those questions. But so I think you're right that patients that have the that are herniating, basically, do you lower the blood pressure as aggressively in those patients? Those are the patients where, once again, we don't know for sure, but that is a concern. That's a potential concern. I will admit that we, at our center, we still go for 160, but those are the patients that are either going to the operating room or getting intracranial monitoring at our place. And then we're trying to make some decisions based on what that patient's individual situation is. Because that's somebody who, if I was going to pick a patient that is at risk for that secondary low perfusion because you've lowered the blood pressure too fast, and that, especially if that patient may have uncontrolled hypertension out in the outpatient setting, and so their autoregulation curve may have been running 240 over 120 for months, and now I lower on that and they're herniating. I worry about that patient, and so that's the patient that we're. But what I don't know is I can't just pick 190 in that patient. So I use my, and then I monitor and then try to solve that issue. The issue of you're going to have to remind me of your second one, but the GCS 15, who do we do surgery on? It depends on what you're doing it for. Those are patients where we are usually not doing surgery for. We're usually doing surgery for level of consciousness, not other aspects of function. Now, I would say that's an open question. Could you have somebody who's a GCS 15 with a big basal ganglia hematoma, and you take out the hematoma and they're no longer paralyzed on the other side, and that's meaningful, very meaningful to them? Very possibly. I think in order to start to select patients like that, then we're going to have to figure out how to use advanced neuroimaging like diffusion tensor imaging. If patients have wiped out their corticospinal tract, probably not going to matter. If they're displacing it, maybe that would be a patient that would be of benefit. but we're not really currently doing that unless we're doing the surgery for an AVM or a dural fistula or something like that. And I'm sorry, what was your middle question?
Yeah, I mean, those patients who have difficult to have blood pressure control by medication, I always find that surgery helpful. Yeah.
Yeah, isn't that interesting? And I think that some of that goes back to the fact that almost everybody who comes in with an ICH is hypertensive. So some of this hypertension is reactive. And so it's a package of care. It's a package of care. Now, I will admit that doing surgery for blood pressure control itself, not really something that we're pushing. But could this make a difference in a patient that's really unstable and difficult to control? Yeah, sure. It's a good observation. And I think others, including us, have seen that on individual cases.
Thank you, Professor.
Professor, I'm Phil. If I may ask you a few questions. First of all, let me congratulate you for this wonderful lecture. And it is a most common scene that we encounter in neurosurgical practice in low and middle income countries. The most commonly encountered problem is that of the patient who is on aspirin and clopidogrel, because in the 40s and 50s, many people have cardiac disease, and these are the patients who are taking it, and they suddenly come to you with an intracerebral hematoma. And as you showed in the patch trial, that giving platelets to this patient is really harmful, as this study shows. But what is the logic? We must understand that we give these platelets to improve the quality of platelet coagulation, and we believe that it aids in hemostasis during surgery as well. So what do you think is contributing this adverse effects? And in your place, what do you do with patients who are taking aspirin and clopidogrel who come with intracerebral bleed?
Well, and I think the investigators in Patch, I mean, they did the study because they thought platelet transfusions were going to be good. They weren't really trying to prove them bad. They thought that was going to be good, and that was going to be a new treatment that we have. I think that transfusion reactions probably are part of it. The inflammatory response that happens when we give transfusions must be part of it. And I think the impact of aspirin is probably real, but not huge. So, what do? Is we generally do not do transfusions, even for patients that are going to the operating room or getting intracranial pressure monitors or ventriculostomies, if it's aspirin alone. What we do, though, is if somebody's got on clopidogrel, we do serial CT scans. I mean, in pretty much all of our ICH patients, we'll do a CAT scan, and we'll do a follow-up CAT scan in 6 to 12 hours. If they're expanding, we will usually give them a platelet transfusion then and DDAVP if they're on clopidogrel, or if they're on ticagrelor or prasugrel, those sort of other ones as well. Maybe that's too little too late, but that's what we tend to do. Also, if patients are going to the operating room, especially if they have a spot sign and they're on clopidogrel, we actually do tend to do it. But I don't know whether that's right or not. But I think that it is appropriate to be careful with the results of the Patch study as they relate to non-aspirin or operative patients, and admit that we're not really sure.
Thank you. Another very important question that I would like to ask is, in patients who are on anticoagulants with a prosthetic heart valve, the dilemma of stopping those anticoagulants in these patients versus taking them for surgery. What are your feelings on that? What do you do in your place?
Yeah, so I don't believe these patients have really been looked at in terms of randomized trials, but there's a pretty fair amount of experience in terms of cohort studies looking at this. And these patients ought to be reversed acutely. These patients should be reversed acutely. This concern that of like causing the valve to acutely clot or something like that is a pretty low risk acutely. So they should be reversed. Usually these patients are on vitamin K antagonists because the direct acting oral anticoagulants don't seem to to be good for mechanical heart valves. And so they ought to be reversed, and then we ought to treat them the way we're going to treat them. The question is, when do you restart? And a number of studies have looked at this, and while we may wait a month or more in patients with atrial fibrillation or so forth, probably the sweet spot for restarting anticoagulation in the mechanical valve patients is at plus or minus 10 days. It seems that the first week or so, hemorrhagic complications predominate. After about 2 weeks, ischemic complications predominate. And in that 1 week middle period between the two, then that 7 to 14 days, it's probably about the same. And so we're generally thinking about it at about a week, maybe starting warfarin without bridging heparin or things like that, because then it takes a few days to then come back up.
Thank you very much. Liu, over to you.
Yeah, thanks for a very lively discussion, and many questions arise from this lecture. Before ending, we would hand over to Professor Dbs for a closing comment or remarks, Professor.
Well, first of all, the organizers, thank you. Thank you for this forum and allowing us to host Dr. Hemphill, who authored, one of the key authors of this guideline, and this all these questions and thought-provoking, and I think we can keep dragging, and hopefully someday we can, you know, do even better what we do for our ICH patients. So thank you, Dr. Hemphill, appreciate it, and thank you to the organizers.
My pleasure.
Thank you very much, Professor Hemphill, for joining us, and Professor Dbs for chairing this session. Now we're going to end our session.
On behalf of the Education Committee of the ACNS and the President, Professor Yoko Kaito, I would like to thank both the speakers of today, Professor Krishna Kumar and Professor Claude Hemphill, as well as the chairs, Professor Jamil Deboo and Professor Basant Pant. A huge gratitude to our Vice President of ACNS, Professor Shubin, for broadcasting this on the WeChat channel. And as Liu mentioned, there were around 850 people who joined us from across the world on 3 combined platforms. So until we all meet on Saturday, it is bye-bye from all of us. Thank you very much for joining.